Okay, a very, very warm welcome to everyone, and welcome to the second of our webinar series on speech management for children with cleft lip palate state of the art. And this webinar series is organized by the Cleft, Palate and Craniofacial Conditions Committee of the International Association of Communication Sciences and Disorders, IALP. Before we begin today's webinar, I will briefly introduce the association as well as our committee and our committee members. The IACSD is a non-profit, non-political and non-governmental worldwide organization of professionals and scientists in communication, voice, speech-language therapy and pathology, audiology and swallowing. And the organization was founded in 1924 by Velopharyngeal. It also actively collaborates with the World Health Organization. And our current president is the esteemed Professor Pam Enderby. And here's a nice photo of her. The association has a global vision to facilitate better understanding, knowledge, and care of all those with communication and swallowing disorders. And its mission is to improve the quality of life of individuals with disorders of communication, speech, language, voice, hearing, and swallowing. Right. There are 14 subcommittees within the association, and the Cleft, Palate and Craniofacial Committee is one of the newer committees in the association. Our work program and activities adhere very closely to the IACSD vision and mission. We have also very recently updated our website. And you can see our link at the bottom of the slide. We now have a frequently asked questions document for the non-specialist speech language therapist in cleft lip palate. We also have a very comprehensive document on links and resources. And all of these are freely available and accessible on the committee website. Members are also part of the task force on the underserved and unserved populations of the IACSD. And in this work, members have produced a chapter on needs and strategies in cleft lip palate aimed at the general public and government officials. Certain members of our committee have also been very active mentors of the Transforming Faces and IALP Seed Mentoring Project, mentoring speech therapists from countries such as Ghana, Uganda, India, Sri Lanka, and Ethiopia. Committee members are also very actively involved in various professional and voluntary bodies and NGOs globally, facilitating networking and collaborative international work. So here we are. There are 8 of us at the present time, and you can see that we represent different parts of the world. And for those of you who attended webinar 1, you would have already met Dr. Trina Sweeney and Dr. Alice Lee. And I will introduce today's speakers, Dr. Debbie Sell and Ms. Yoshiko Take, more formally later on. And the final slide on the IACSD, just to share with all of you about the upcoming 32nd World Congress of the IALP, which will be held in August 2023, so you can plan in advance. It will be held in the lovely Auckland, New Zealand. And please feel free to access the website to read more about the Congress, and also to submit any abstracts. Okay, just a couple of Zoom webinar notes before we begin. Please note that the webinar is being recorded and the entire recording will be uploaded onto our committee website. Speaker PowerPoint slides will also be uploaded, including references for today's webinar. Now, if you have any questions, please feel free to type your questions in the Zoom chat, and members will collate the questions, and speakers and committee members will aim to address all questions in the last 20 to 30 minutes of the webinar during the Q&A session. Now, before I introduce today's speakers, may we just run a very quick poll just to give us an idea of who you are. I think there are only 4 to 5 questions, and answers will be anonymous. So I'm just about to launch the poll. Can I just check if that's being shown or whether it's being shared?
Yes, it's on the screen, Val.
Right, thank you. Okay, I'll just wait for just a couple more seconds. Okay, thank you. Okay, thank you. So we have quite a proportion in the audience who have experience working with children with cleft lip and palate. And for those who have the experience, it is majority answered less than a year, followed by 1 to 5 years, 10 years, more than 10 years, and between 5 to 10 years. And in terms of how many children with cleft lip and palate do you currently have on your caseload? 1 to 5 was the most ticked response. And in which setting? That's across all settings. It seems to be equal proportions across cleft team, hospital setting, community care, schools, and private setting. Great, thank you very much. Okay. Now, so the first of our webinars, series of webinars, was held on the 20th of January, and our 2 excellent speakers were Dr. Sweeney and Dr. Alice Lee. And I made the error of not introducing them properly or formally in more detail. So apologies, Trina and Alice. So I'm going to do that now. Dr. Trina Sweeney is a cleft specialist speech language therapist and a founder and co-director with Dr. Debbie Sell of Speech at Home. She's also currently deputy chair for our committee, member of the trial steering committee for an international trial on timing of palate surgery, an executive committee member for the upcoming 14th International Congress of Cleft Lip and Palate and related craniofacial anomalies, which is to be held in Edinburgh. And Dr. Trina Sweeney is also an honorary member of the Craniofacial Society of Great Britain and Ireland. Dr. Alice Lee is a speech and language therapist and lecturer in speech and language sciences at University College Cork in Ireland. Her research interests and expertise include perceptual and instrumental investigations of speech disorders associated with structural anomalies and neurological impairment, listener training for auditory perceptual judgments of speech disorders, and the Cochrane Systematic Review. Dr. Lee is also a steering group member of DLAD and a member of the United Kingdom Child Speech Disorder Research Network. She was also the editor of Journal of Clinical Speech and Language Studies, the official journal of the Irish Association of Speech and Language Therapists. Now, recordings of Dr. Lee's and Dr. Sweeney's talks, as well as their PowerPoint slides and references, are uploaded onto the committee website. So please do access them if you have not had the chance to do so. Okay, and right, so I now have great pleasure to introduce the two speakers for today. Dr. Debbie Sell is a senior research fellow at Great Ormond Street, and until 2018, she was also a speech and language therapist in the North Thames Regional Cleft Service. Previously in managerial and leadership roles, Debbie now focuses on research, mentoring, supervision, teaching, and independent clinical practice. Her PhD study in Sri Lanka, speech in patients with unoperated and late-operated cleft palate, led to its speech and language therapy training course. Dr. Sell has also led on developing and testing speech outcome tools in cleft palate and velopharyngeal insufficiency, setting standards for measuring speech outcomes, and she has also participated in several multi-center national and international studies of speech outcome. Debbie's current interests are parents undertaking articulation therapy in children with cleft palate, supported by therapists and technology, and is founder and co-director with Dr. Trina Sweeney of Speech at Home. So we welcome Dr. Debbie Sell as one of our two speakers today. Our second speaker is Ms. Yoshiko Take, and Yoshiko is head speech and language hearing therapist at the Department of Oral Rehabilitation, Showa University Dental Hospital in Tokyo, Japan. And she specializes in children and adults with speech sound disorders and speech problems associated with cleft palate, head and neck cancer, ankylosing, neurological and muscular diseases as well. Since she collaborates and works closely with dentists, her clinical research relating to cleft palate focuses on the treatment of velopharyngeal dysfunction by combining speech therapy with speech aid prosthesis. Ms. Take also teaches courses regarding speech in several institutions for speech, language, and hearing therapy students, as well as dental students. In the recent years, Yoshiko has also been involved in developing Japanese cleft palate speech assessment tools. So welcome, Ms. Take, as one of our two speakers as well. And now I'm very happily handing over to our speakers for today.
Right. Well, thank you very much for that introduction, Val, and good morning, good afternoon, good evening, not good night, to you all. We're delighted that you are here today. So Yoshiko and I are going to share this presentation, and this is the structure to the presentation. I'm going to talk about perceptual assessment and then hand over to Yoshiko to talk about supplementary approaches, the oral examination, instrumentation in relation to the assessment of velopharyngeal dysfunction, and then I'm going to finish on the broader aspects of speech assessment. Here we can see the International Classification of Function, Disability and Health. And of course, in Cleft, much of our emphasis has been on this part, body functions and structures. And that's where the perceptual assessment sits. We'll look further at these other areas later in this talk. So the perceptual speech assessment in Cleft is perhaps a little bit unique in the sense that it's used for multiple purposes. Yes, clinical assessment, the focus of today, in fact, but in addition, therapists in Cleft teams have a responsibility to audit the outcomes of the surgical team through audits, and also that information going into national registries. And indeed, we also have a research role in terms of not only our own outcomes, but that of surgeons, and informing the appropriate surgical protocols. So when we look at this area of the slide, not the clinical piece, the world of speech and language therapists have done a lot of work on how we target, how we describe our outcomes. And we now have services which are characterized by high quality speech recordings, agreed speech samples, and the use of trained, reliable listeners. And indeed, when we're thinking of research, those listeners are independent of the team. But as I've indicated, what's important for us today is to think about the clinical assessment. So there are additional risk factors for speech problems in children with cleft or velopharyngeal dysfunction. And one of those is the fact that the palate doesn't shut off the nose from the mouth during speech efficiently, velopharyngeal dysfunction, VPD. In addition, there are other structural anomalies, which are fistulae, occlusion, dentition, which we'll hear about from Yoshiko. And hearing is an issue, as we heard in the last webinar. And in addition, the syndromic diagnoses in our patients. There are more than 400 described, but commonly about 30 that are seen in the clinics. So why is cleft speech perceptual assessment more challenging? This is a common perception. And it is correct that it is more challenging because cleft palate speech is complex. Not only does this involve articulation, as in other speech sound disorders, but you've also got nasality, nasal airflow, and the voice is also implicated. So we have several parameters which interact, and you're assessing them at the same time. Then we see that we have sounds that may not occur in a sound system of a language, such as implosives, or rarely occur, like the clicks that Trina demonstrated last webinar. Our standard to capture the detail we need is narrow phonetic transcription, and we need that to be reliable. But one point of interest is that we commonly say that cleft speech is universal, and the characteristics are indeed, but there's increasing evidence of the impact of the language differences in phonology emerging as we learn more about cleft in different languages. And we'll see this in a moment. So I've said that there is this need for narrowed phonetic transcription, not only because that's at the core of what we do as speech therapists, and it's our unique selling point, if you like, in the cleft team. It's what we can bring to that team particularly. And Howard and Hesselward talk about it as being indispensable, and it is in cleft children. We base this on the International Phonetics Alphabet, the IPA, and its extensions, which were published in 2015. And there are some helpful websites now available, several here listed. But if you look at these here, there are an enormous number of different diacritics, and it can be rather overwhelming. So we do have this phonetic crib sheet, which is available, which is really trying to summarize those that are the most common diacritics you need. So this morning, what I'm going to do is to use the clinical assessment that we use in the UK to just demonstrate some of the aspects of what we need to assess. So this particular assessment is called the Great Ormond Street Speech Assessment, the GOSPAS. And it's two forms, and we're going to focus on this front form for the moment. And it's a systematic approach. It allows you to document what you're hearing in front of you in a very concise way. It is a screening assessment. And we have an agreed speech sample. We'll talk about that in a moment. And in addition, there is a training DVD that goes with it. So let's just think about the standard speech assessment. So in Cleft teams in the UK, we have agreed this, as have other countries now, with all of the work of the CLISP website, which is an excellent website. And our samples consist of, as you might expect, conversational speech. We include rote speech, and people do use single word samples, but we definitely always include sentence repetition. There are 16 sentences, including mainly high pressure consonants, but a mixture. There are also some with low pressure and nasal sentences. So here is a high pressure, a low pressure, and obviously the nasal sentence there. So if we're going to be looking at how we would transcribe our sentences, so each sentence has the target here, and we have the initial position here and the final position here. So Tim is putting a hat on, T initial, T final. And in the clinical assessment, you can use any other words that you hear to note down, particularly when there's variability and in your patient. So you go along here listening to each sentence and you transcribe what you hear, and in the different positions. And then you take this information and you then code it into the Cleft speech characteristics as Trina described in the last webinar. So just a reminder of that, we know we've got the different groups. There are 4 groups of different Cleft speech characteristics, and then the different types of characteristics which come into each group. So now let's see how this works in practice. So here there's some data that I've put into the GOSPAS in the initial and word final positions. So what can we see? We can see nasal fricatives for the lingual fricatives S, Z, and SH. And this backing to velar for the targets as listed here. In addition, word final, glottal stops. And this is what's an interesting point, that in working with Yoshiko for this talk, she told me, of course, that Japanese doesn't have any word final consonants. So we can imagine their speakers are going to be different to our speaker. So then what happens is you would look at your data and code it to the Cleft speech characteristics below. So the blue comes down here to backing to velar. You list the consonants affected, so you know there are 5 consonants affected there. Then you code your glottal articulation here and your nasal fricatives here. In addition, you can see this patient has an example of stopping, a developmental error, which are common in Cleft speakers too. So we're able to code that information. But what this allows you to see is obviously the pattern of errors that the patient has. So we can see that we've got a pattern of word final deletion with glottal stops. We can see this nasal fricative predominance for the lingual fricatives, but this fricative here, which is ringed, is correct. So you get some sense of a phonological analysis. It's a screening test, so it's not an in-depth analysis. But if we remember what phonological analysis is, what it does is to identify the error processes, i.e. the backing to velar and glottals, or the patterns in sound classes, i.e. the fricative class, the lingual fricatives, those nasal fricatives, and the specific contexts, those word final glottal stops. And of course, when we have this happening, we would see that the patient will have an inability to signal meaningful contrasts. So we could see there some developmental immaturities leading to phonological delay, and the Cleft speech characteristics would be phonological disorder. And Harding Bell and Howard have used this term, which we often describe in our Cleft speakers as phonetic constraints with phonological consequences. So the phonological part of Cleft speech disorders we've really learned much more about that in recent years. I now just want to look at another way of looking at a data set. So the universal parameters was recommended as a tool for collecting outcome data and not for clinical purposes, but it is in fact often used for this. So what I wanted to show is, okay, I'm going to take that data I've just looked at and I'm going to map it onto this system, which is a description of presence or absence of those particular processes or cleft speech characteristics. And you can see there we've ticked all of those that have occurred, and here we've got the developmental errors. But I hope you can see how this approach doesn't give you any information about the frequency of occurrence of those articulations or those errors. It doesn't tell you which consonants have been affected, and neither do you get any sense of the impact on the phonology and the ability to make meaningful contrasts. Okay, I'm now going to move into another really, really important part of cleft speech assessment, and it's stimulability. So the ability to copy consonants or imitate consonants. We'll look at the definition in one moment. It's an important part of the assessment because it allows you at that point in time to decide if my patient who's not able to do these sounds, but when I do them in isolation in this way, can they make changes with their current structure? And it informs the therapy program. So it goes towards this picture that you're getting of your patient. If we look at the definitions, which is very interesting, these are from the speech sound disorder literature, because I didn't find one in the cleft literature, in fact. Mikio talks about its ability to immediately modify a speech production error when presented with an auditory and visual mode. Bernthal et al. In 2017 said that one shouldn't provide additional phonetic cues. I thought about this and I thought, well, hold on a minute. I think in cleft assessment, we do give additional instructions when we're trying sounds out in this part of the assessment. For example, if they're not doing the t sound, we might give them the idea to bring the tongue tip between the teeth and show them that. Or we might test out an S using a novel sound, such as stretching a t, so it becomes ts, ts, and you get your S facilitated by that t. So if we go back to the GOS-PASS, we put our stimulability above these targets, and we can see that actually this patient was able to do that t there, so that's excellent, such suggesting some room for maybe therapy treatment. But when we did the S, they immediately did the nasal fricative. If we gave them a bit more of a prompt by stretching out that T that we got them to do, we did see that they were able to get some fricative at the end of your T. So, and again here, the T for the ch, and again, we did a T and a Y, and actually a little step into what they might be able to do in therapy. So I think our stimulability is a little bit different to some of the speech sound disorder work, perhaps. So moving away from the speech sound disorder bit, the constant production bit, which you've done down here, we're just going to look now at those parameters of resonance, emission, turbulence, and grimace, which Trina talked about last time. When we're assessing these, we do look at severity and consistency. So in terms of severity, they're often described as mild, moderate, severe. And we know for hypernasality that if those scalar points are defined, we have better reliability. In terms of consistency, it could be a consistency of a target in different word positions. It could be consistency within a sound class, i.e. your plosives, for example. It could be across the speech hierarchy. So is there some differences between what's going on at syllable level to word level? Now let's think about hypernasality. Just a reminder here of the definitions Trina used, and also the actual phonetic transcription. Hypernasality is complex to rate as it's influenced by lots of factors, and therefore reliability is challenging and variable in the literature. So some of those factors are the speech characteristics themselves. Some of it is down to the listener. and whether they've got a cold on the day and volume. So it is a challenging parameter at times. But let's think of some helpful tips. So if you isolate your low pressure sentence or sentences where there are no non-oral and nasal airflow errors, it is easier to rate hypernasality. So in English, that sentence would be, we were away all year. You do not have non-oral and nasal airflow errors. And in Japanese,
青い家はいいよ.
thank you, Yoshiko. In addition, another clue may be that actually, if your P and B targets are correct, but all of the lingual consonant pressure, high pressure consonants maybe are a problem, use your P and B, for example, in syllables such as pa, 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 p, 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 or words such as in English, we could do pepper, 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 paper, 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 because that actually, again, is words in which there is a pressure consonant and yet free of any errors, and you'll get another indication of their hypernasality or not. And active nasal fricatives, particularly if they are affecting, say, all of the fricatives and affricates, which they can do, that can lead to a false impression of, gosh, they're really hypernasal, there must be a structural problem, and we'll hear more about that in a moment. Let's think about hyponasality, and just focusing here on its association with a nasal obstruction. So the case history is important here. Do they have a cold? Have they had a pharyngoplasty? They are more likely to be hyponasal. In bilateral cleft lip and palate and unilateral cleft lip and palate, deviated nasal septum and enlarged turbinates are common. That may be a contributor. And of course, enlarged tonsils and adenoids. So let's think about a tip for those. Listen to your nasal loaded sentence. In English, Mum came home early, and in Japanese,
ママは豆をまいた.
thank you. And one thing to say, sometimes hypo and hypernasality may co-occur, particularly when there is pharyngoplasty and it's bilateral cleft lip and palate, perhaps unilateral cleft lip and palate. Let's now go on to the nasal airflow errors. So here we can see we recall from Trina's speech talk, the emission, the hissy, the phonetic transcription, and nasal turbulence. It's a turbulent sound and phonetic transcription. And we can see that these here are accompanying the production of those consonants. The consonant is correct, albeit with this accompanying abnormal emission or turbulence. In addition, it could be that one of these is completely replacing the nasal fricative affricate, as we've just seen, and this would be the transcription for the active nasal fricative. And again, rating severity and consistency. One of the things that we are aware of is that these are not heard on glottal and pharyngeal articulation, and they're not heard on low pressure sentences. So again, you can strip out some of these factors that sometimes can make listening very difficult. A nasal emission, the source can be either a fistula here, or it could be both. And we'll hear from Yoshiko in a moment what we do about actually deciding where the source of air leak is. And that's important because obviously we need to say to the surgeon, please repair the fistula, or please do something at the back, or please do both. So that's the whole purpose of that. We also have grimace. This is a speech accompanying behavior affecting the visual appearance of speech, and it's on a sort of graded scale of severity, from just some flaring of the nostrils through to nasal grimace through to facial grimace. And again, a consistency rating is given. The important thing about grimace is that it can indicate an unconscious effort to close the velopharynx, an indicator of VPI, or it may behave period of velopharyngeal sufficiency They've gone on, and the surgery is but the learnt behaviour and need intervention from therapist. So here I can just show you that GOSPAS. Oh, that's all I need. The GOSPAS with the ratings on this patient, and as we can see, there wasn't too much noise actually in this particular sample. Now, voice is another area that is important because it can make our perceptual assessment difficult. We heard from Trina how there are structural laryngeal pathologies associated with some syndromes. For example, 22q, in 10%, they have a laryngeal web. The majority, however, are muscle tension voice disorders with or without mucosal changes such as inflammation and vocal nodules. The causes of these voice disorders in this group are probably likely to be multifactorial, such as compensation, hyperfunction in your non-oral articulation and compensation for your velopharyngeal dysfunction, a conductive hearing loss and nasal breathing, and of course psychogenic aspects as well, as in other voice cases. And I suppose one of the things to say is it's one of those interacting parameters that makes sometimes the assessment of nasality very difficult, and dysphonia can really mask the degree of hypernasality. Another rating, which is actually the final rating to think about, and has only really been introduced, as you can see, very recently by work from Lomander et al. And Brunegard, is the use of the VPC rate rating, which is a perceptual judgment of velopharyngeal function based on connected speech for clinical purposes. It's a validated 3-point scale of competent or sufficient, marginally incompetent, insufficient, or incompetent, insufficient. And it's come out of the work of Svante, the assessment used in Sweden. So having done this assessment, we then get to the point of differential diagnosis, and we're looking at abnormal resonance, hypernasality, hyponasality, and with or without accompanying nasal airflow. And your speech sound disorder may be related or unrelated to the current or history of structural constraints. So for example, glottal stops prior to surgery, a VPT surgery, will persist after the VPT surgery, even if that surgery has been effective and successful. The issue of consequences phonologically, and we know that we also see dyspraxia, and particularly in the non-cleft VPD cases, and others I'll show you in a moment, and the hearing related type characteristics. So on the back page of GOSPAS, we have a space to actually summarize all the etiology that we think is relevant to this speech disorder. Once we've decided that, we might then send them to other disciplines within the team, and for opinions such as dentists and surgeons and audiology and psychology. Our major thing is to try and work out the potential for therapy, and most importantly, the need for investigations of velopharyngeal dysfunction and physical management. So I'm now going to hand over to Yoshi.